We're about ready to go.
All right. Good morning, everyone. It is my pleasure to introduce Dr. Hiram Rivas-Perez, Associate Professor of Medicine and Program Director at Division of Pulmonary Critical Care. Dr. Perez did his undergrad, medical school, and residency at University of Puerto Rico and his fellowship at Ohio State, and he served as a chief fellow in his last year. We were fortunate enough to have him join us in 2014, and he did a tremendous job. His interest was education and training, and he served as an associate program director from 2016 to 2018, and then program director from 2018. And he also served as the director of the Dept lab. And the accomplishment for Dr. Perez doesn't really stop at being just a program director. He interest is in COPD and airway disease, bronchiectasis, and asthma. He had a lot of trials and studies are done, pharmaceutically initiated and investigator-initiated trials. He's very active in the ETS and was recently selected as an associate editor of the new ETS journal, Scholar Journal, and is also editor of the in-service exam for the Pulmonary Critical Care Fellow. His topic today is about management and treatment of non-CF bronchiectasis, and I think this is a really important topic for the house staff and internal medicine, and I'm pretty sure that you are going to learn a lot from this talk. So thank you, Dr. Rivas-Perez. Go ahead.
All right. Thank you, Mohammed, for that introduction. Good morning, everyone. As Dr. Saad was saying, I've been working for the past 6 years in the clinical setting on obstructive lung diseases, and I have a fair amount of patients with non-CF bronchiectasis. So I felt like this was the right opportunity to talk about this topic that I don't think we cover much. I have no disclosures. I'm doing several clinical trials, but that's for this topic today. Today we're going to focus on the important things, an overview on bronchiectasis, epidemiology, the pathogenesis. I won't spend most of the time today talking about diagnosis and management. The diagnosis tends to be pretty extensive and sometimes very hard to come up to a reason why a patient has bronchiectasis. And then within management, I'm going to point out how much of the management we extrapolate from the CF evidence, which of the interventions that we do for cystic fibrosis works, which interventions do not work for non-CF bronchiectasis. And hopefully we'll have time to go over some additional cases that are important that you may see in your practice. So I always like to start all my lectures with a real case, and this is a patient that went across several of the subspecialties, so some of you may have taken care of her. She's a 76-year-old woman with history of frequent pneumonias, chronic cough. She comes to the clinic because she's very frustrated with her care. She's been hospitalized 3 times in a year for what she says is pneumonia. She gets antibiotics and sometimes steroids, and the symptoms don't get better. She reports that her cough is productive and daily, that now her shortness of breath is so bad to the point that she has shortness of breath at rest. And she has no history of smoking, and she does have a history of recurrent sinusitis. She points out in the review assistant that she does have some heartburn. Sometimes it's bad enough that she throws up. She's getting tired of being hospitalized. I was probably her 4th lung doctor that she was seeing. And on physical exam, the only thing remarkable was that she has some expiratory wheezing, specifically at the left lower base. The first appointment, she had pulmonary function test, showed moderate obstruction. Previously, she saw a different doctor that had a sweat chloride test, which is a test that we do for cystic fibrosis, that was negative. I ordered an alpha-1 antitrypsin genotype, which was normal, which is MM. And again, I point out that she had reflux and was on protonics for the reflux. After my meeting, I ordered this X-ray, and I'm just going to point out a few things. Sometimes a little hard to visualize in your monitor in the computer, but she does have some low volume, specifically on the left lung. Left heart border looks a little big. I just want to point out just more increased interstitial markings, specifically at this, what I'm putting my cursor here on the right base and a little bit on the left base, but otherwise nothing that really a diagnosis. I think this was an X-ray that she got on an ER and was diagnosed with left lower lobe pneumonia. Based on some of her symptoms, I opted to get a high resolution chest CT. This is just a few screenshots of her CT scan, mostly at the bases. You see low volume. She had severe scoliosis, which also contributed to some of her shortness of breath. The most important thing is here at the right lower and the left lower, you see these dilated airways with thick wall. This is mostly mucus around the wall, and here you see it at the left lower. Very low volumes on this left lower lobe, and some thin broad opacities. So this patient was diagnosed with bronchiectasis, but the key here, what I want to talk about today, is you make the diagnosis of bronchiectasis, but after that you have to determine why the patient has bronchiectasis. And after a whole year of workup, she ended up getting an impedance study, and she had so bad of a reflux that she was microaspirating, and that's why she had bronchiectasis at the lower lobes. And once we controlled her reflux, her symptoms started getting better. Bronchiectasis is not a new diagnosis. This is René Laennec. He was the inventor of the stethoscope. He described a lot of the pulmonary diseases that we take care of today. Back in 1816 was probably the first time that there was described something similar to bronchiectasis. He was really interested in patients with tuberculosis and what happened with those patients after they contracted the infection. And he described a group of patients, most of them were men, short stature, about 5'3", that had productive cough, significant volume of sputum secretions. And with the stethoscope, he described some of the physical exam, which were some wheezing. So that was probably the first time that bronchiectasis was described. Bronchiectasis, the term of the means comes from the Greek, is basically dilated windpipe. And it was not until later, several decades later, when bronchography was created, that the description of bronchiectasis based on imaging was done. But it was as early as 1816. The definition is a radiologic definition. The internal diameter of a bronchus on a high-resolution chest CT, it's larger than the accompanying vessel, and it has several examples today. In addition to that, the bronchus fails to taper to the periphery of the chest. Interestingly, with bronchiectasis, when you look at the numbers and the prevalence and the incidence, depending on where you look, you're going to get different numbers. This was from a study from 2017 that reviewed and said that the incidence increased, the prevalence increased from 2001 to 2013 by about 8.7%. The description here is about 139 cases per 100,000. The incidence of 29 cases per 100,000. The peak ages in this study of diagnosis were older populations, 80 to 84-year-old, more common in women, and a higher prevalence in the Asian population. We do have a U.S. bronchiectasis registry. The most updated data in the registry is from 3 years ago. It only has registered about 1,800 patients with non-CF bronchiectasis. And the numbers are a little different. The mean age of the patients registered is about 64 years, more common in non-Hispanic white subjects, about 89%. Here is very similar to the previous reference. Women are more common to have bronchiectasis, 79%. That never smoked. Were within those 79% of women, 60% never smoked. And what's interesting here is the most common comorbidities reported were GERD, asthma, and COPD, which I'm going to talk about several times today. It's a very costly condition. It costs about $630 million annually, not only from hospitals, from ER visits to office visits, and The mortality varies. Again, the data as far as incidence and prevalence also varies depending on the study. The mortality range from 10 to 16% over a 4-year period in a study done almost 13 years ago. And the most common cause of death was related to respiratory failure. Normally, these patients have severe pneumonias and end up developing respiratory failure, which they don't survive. There's several causes of bronchiectasis, but there's 4 specific insults or risk factors that it's already known that triggers the process of developing dilated airways. One is an infectious insult, impaired drainage of the mucus, which is the problem with cystic fibrosis. If there's any airway obstruction, which also leads to impaired mucus or impaired drainage, or if a patient has any defect in the immune system, any immunodeficiency. The problems with bronchiectasis are mostly led by a neutrophil inflammation. So once you have an infectious insult or impaired drainage, you have an abnormal inflammatory response by the neutrophil, specifically the protease. That leads to airway destruction and distortion of the airways. The airways become dilated, and there is a problem with the mucus clearance system in the airways. That leads to bacterial colonization that also triggers more neutrophils, and it's a vicious cycle. And that is what leads to the progression of bronchiectasis. If I get a biopsy of a bronchial wall, this is what I'm going to see. On the left side of your screen, you're going to see a bronchial wall of a patient with bronchiectasis. On the right is a normal bronchial wall. On the left, what I'm pointing out here is the change in the epithelium to pseudostratified columnar epithelium here. There's also a lot of inflammatory response, mostly lymphocytes, compared to the one on the right, which is normal. And then this is a different view where you see more at the microscope how the airways are dilated with significant inflammation. The causes are multiple, more than this actually. There's probably another dozen of the causes. I just point out the most common ones. As I said earlier, an infectious cause, an infectious trigger that on a patient that has impaired mucus clearance can be one cause. Immunodeficiencies, cystic fibrosis. I'm not going to talk about cystic fibrosis today. Tracheobronchomalacia, that's easily can be missed. Tracheobronchomalacia is the main airways and also the distal airways are lose some of the elasticity and kind of collapses, specifically with exhalation. Patients with severe bronchomalacia do not necessarily have a problem with parenchyma, but they're not able to clear the secretions, and that can lead to frequent infections and pneumonias, and eventually lead to bronchiectasis. Alpha-1 antitrypsin deficiency is another cause. Patients with COPD, that's very, very common, and I'm going to spend a little time talking about that. Some autoimmune diseases, ciliary dysfunction, which is mostly a problem, like or a defect with the airway clearance. Some vascular diseases, rheumatic disease. Frequent aspiration as the case that I open up this presentation. Lung cancer or any kind of cancer that has mets to the lung that can lead to any kind of airway occlusion can also cause it. And of course, the one that I hate the most when I do this expensive workup and I cannot find that out ends up being idiopathic. The diagnosis, as always, history and physical exam is important. This US registry of close to 2,000 patients with bronchiectasis. These are the most common symptoms. It's not going to add up to 100 because some of the symptoms overlap. So cough is the most common, up to 73%, and daily sputum production. Patients can have some rhinosinusitis. Fatigue is very common. Frequent infections. Patients can have hemoptysis. And in some cases, it's difficult to treat asthma. That's always very important to keep in mind if you have a patient with frequent asthma exacerbations. But as you can see, some of these symptoms may not be necessarily specific. So in addition to the diagnosis, X-ray may help. In severe cases, on an X-ray, you can see some tract changes. If a patient has cylindrical bronchiectasis, If you have a patient with an airway that is dilated, with can have an air fluid level, which means that there's mucus and inflammation inside that airway, and you can see increased bronchovascular markings. This is an example of an X-ray. This is an X-ray of a cystic fibrosis patient. I used it just to point out what the findings of a patient with bronchiectasis. But you probably can see here some of the dilated airways here, some increased bronchovascular opacities. But to make the diagnosis, you need a high-resolution chest CT. So in the high-resolution chest CT, the bronchus has to be visualized within 1 centimeter of the pleural surface, so a dilated airway that goes all the way to the periphery. There's a lack of tapering of that airway. Normally, the diameter of a bronchus should be about 0.6 to 1 times of the adjacent pulmonary artery. If the bronchus is 1.5, the diameter bigger than the vessel, that's already diagnostic of bronchiectasis. And then you see bronchial wall thickening, which is the mucus inflammation. And in some cases, you can see some mucus impaction within those dilated airways. Several examples. These are all cuts from the same patient. I'm just going to point out a few things. You see the dilated airway tracking all the way to the periphery, very close to the periphery. You can see here multiple airways that are dilated. This here is a good example of an airway that is bigger than the accompanying vessel. Here you see a cluster of dilated airways here to the right, upper right of the screen, and associated wall thickening. This is the mucus. And here another example of the airway being bigger than the accompanying vessel. And the same at the bottom of the screen, similar examples. This going back to the same original case. Again, dilated airways, bigger than the accompanying vessel with associated inflammation. This is probably chronic infection. And again, this is a dilated airway with a thick wall. This is mostly mucus and inflammation. The dilated airway here, bigger than the accompanying vessel. This is called the signet ring sign. So that's for the residents. And the airway tracking all the way to the periphery. So those are typical findings for patients with bronchiectasis. Now, important, once you get the high resolution chest CT, you get the diagnosis. Patients can have normal breathing tests. The most common breathing test abnormality is going to be obstruction. So that's also important to add on to the diagnosis. Now, you have a patient that you have a diagnosis of bronchiectasis. So what? What is the next step? So important, always exclude cystic fibrosis. To exclude cystic fibrosis, you need 2 sweat chloride measurements that are negative and a gene testing. And according to the CF guidelines, if you have 2 sweat chloride tests that have measurements more than 60 mLs per liter, that are diagnosis of CF. Just to briefly go through the algorithm, so the indications of evaluating someone for CF, if you have anyone that has clinical symptoms suggestive of CF, or a newborn screen, or a sibling with CF, then you do the sweat chloride testing. More for reference, in infants, we normally wait until 2 weeks, and they're more 2 kilos of weight if they're asymptomatic. An abnormal test is a sweat chloride more than 60. And after you get a normal test, you do DNA testing. If the patient has 2 CF mutations, that is going to be the diagnostic of CF. A normal test is going to be minus 29, less than 29 in sweat chloride, or less than 39 in older infants or adults. I want to focus on this category because it seems to be one that gives me the most problem, is when the sweat chloride is in intermediate, which is 30 to 59 mLs per liter. If that's the case, you do DNA testing. If you have 2 CF mutations, you already diagnose CF. If you have 1 CF mutation, then you have to repeat the sweat chloride test or do an expanded DNA analysis to make the diagnosis. So this is the part that is very difficult. The differences between CF and non-CF bronchiectasis. This is a good table that summarizes the difference between CF in childhood, adult CF, and non-CF bronchiectasis. Cystic fibrosis is normally in child's adult CF is more than 18 years and non-CF more than 60. The gender and for CF is no gender difference. In adult CF is more common in women, and the same for non-CF bronchiectasis. CF is usually upper lobe predominance, but with progression of can be in all the lobes. On non-CF bronchiectasis tends to be more lower lobe predominant. On childhood CF, they tend to have severe lung and GI disease. The adult CF, it's equally severe, the lung and the GI, less than the childhood. And then non-CF, it depends on the other comorbidities that this patient has. And the etiology, as I said, I mean, for CF is CF mutations, and non-CF bronchiectasis is infection, or post-infection is the most common. The other comorbid condition, CF, that not only affects lung, it affects other organs, pancreatic insufficiency, sinusitis, nasal polyps, and non-CF bronchiectasis. Patients have cardiovascular disease, COPD, asthma, and sinusitis. Remember, it's an older population. They're going to see more issues with the cardiovascular system. The workup on the first, once you make the diagnosis, you get breathing tests. Then important is to get a bacterial and microbacterial sputum culture. It's important to understand what is the bacterial flora that the patient with bronchiectasis have in the lungs. Get immune testing to determine if the patient has any kind of immune deficiency. As I said before, sweat chloride and CFTR, genetic mutation analysis, autoimmune workup, specifically looking for rheumatoid arthritis, alpha-1 antitrypsin deficiency. Look for not only the level or the phenotype. Always remember, if you get an alpha-1 protein, that does not help you at all. It's an acute phase reactant. It can be high in any kind of inflammation or infection. What you need is the actual phenotype. Make sure that you order both. And in some cases, patients are going to need a bronchoscopy to look at the airway, to look if the patient has tracheobronchomalacia, and importantly, to get a good culture and see what other organisms the patient has in the lung. And a GI evaluation, if you think reflux or any GI problem is the culprit of the bronchiectasis. This is also from the US registry. Important to look at what is the microbiome inside the lungs. In this registry, 74% of patients have normal flora. About 33% have Pseudomonas, Staph aureus 12%, Haemophilus influenza 8%, Stenotrophomonas about 5%, and Strep pneumonia 3%. Pseudomonas aeruginosa is a big problem in bronchiectasis, the same as CF. So that's why one of the reasons why it's important to get a sputum culture right at diagnosis. About 63% of some of the patients in some study reported an isolate of non-tuberculous mycobacteria, specifically Mycobacterium avium. So what happens? Why is it important to know if the patient is colonized with any kind of organism? This is a study that looked at what happened with the forced expiratory volume in 1 second in PFTs on patients that had a chronic colonization of Pseudomonas versus the patients that were not colonized with Pseudomonas. The patients that were colonized with Pseudomonas had a quicker drop in liters in a time frame of 2 years, more pronounced than a patient with bronchiectasis that was not colonized with Pseudomonas. So that is very important. So you make the diagnosis, you have the patient with the symptoms, imaging study, breathing test, you do the whole workup, including immune deficiency, sputum cultures, or a BAL if the patient cannot produce any sputum. So how do we treat? And we move on to a different case. So again, an older woman, 71-year-old woman with history of productive cough. She was seen again by 3 different pulmonologists. That's very common what I see in the patients that come to my clinic. She's lost 20 pounds over 6 months. She's been hospitalized 3 times for pneumonias and bronchitis. PFT showed mild obstruction. This patient was colonized with Pseudomonas, and the one previous pulmonologist had her in Staph Staph aureus, had her on a prophylactic, almost 3 antibiotics a month. It was something that I've never seen before. And she ended up having multi-drug resistant bacteria in her sputum. After the long workup, sweat chloride was intermediate. We ended up getting a mutation, and she had one abnormal CF gene. So she did not have the condition of CF, but she did have one abnormal gene, which now what we thought was that she had impaired mucus secretion by just having one defective gene, and that's what led to her bronchiectasis. So again, the key here is identify the potential cause. In 37% of the time, it will affect your management. In addition to that, you can do inhaled bronchodilators in the right setting, airway clearance maneuvers, which is probably the most important intervention for these patients, chronic antibiotics, specifically macrolide, not only for their antibacterial effects, but also for the anti-inflammatory effects, and inhale antibiotics. Airway clearance measures, it can be as easy as hypertonic saline, 3% up to 7%. It can be done through the nebulizer twice a day, 3 times a day. Very easy to do, use, minimal side effects. The other options are positive expiratory pressure devices like the acapella that we use a lot in the hospital, or the flutter valve, high frequency chest wall oscillation, which is the vest. There's several types of vests. Just to avoid any kind of conflict of interest, I'm not going to point out the companies, but there's specific companies that fit based on the size of the patient. Actually try them out on the patients at home, and you can adjust the frequency of the oscillations, and it's very easy to use. The airway clearance measures has already been proven to improve exercise performance as far as distance. This is airway clearance measures using physiotherapy. In addition to improves the 6-minute walk distance in meters, it also improves symptoms as far as the St. George questionnaire, which is a questionnaire of health quality, also improves daily activities and overall quality of life. So with the hypertonic saline, airway clearance measures such as the vest, that's one option. Exercise is key. I think my fellows are tired of seeing the Arnold Schwarzenegger slide that I include in all my lectures. But pulmonary rehab is important for these patients because it improves not only exercise performance and upper and lower extremity endurance, but also teaches them how to cope with their condition. Exercise helps them mobilize that secretions, and it definitely improves quality of life. The important key here is that the patients with bronchiectasis, normally they're going to be colonized with a highly infectious bug through contact. So it's important to point that out to the rehab facilities. Any kind of saline solution is help. This is a comparison between hypertonic and isotonic. They both help as far as quality of life scores. This is a study comparing both, where the hypertonic saline had better numbers on the quality of life on using the St. George questionnaire. Now, a lot has been taken from the CF and therapy. One, and this is an old study that I always like to reference because it has not been able to be reproduced. This is looking at mucolytic therapy because this is very important for CF patients. This is a study looking at what happened with a group that had non-CF bronchiectasis that were given mucolytic therapy, specifically the DNAs, and versus placebo. The PDE and NPD are protocol-defined exacerbations and non-protocol-defined exacerbations. In this study, they defined a exacerbation by having increased sputum production, more than usual, shortness of breath, and worse of cough. And then they added 2 more, which was fever and abnormal imaging finding. That would be the 5, would be protocol-defined exacerbation. Having only 3 of those 5 would be non-protocol-defined exacerbations. In both, in the group on the placebo, they had less exacerbations than the group on the DNA. So this was the first study that showed that mucolytic therapy may not help the patient with non-CF bronchiectasis as much as it helped the CF population. And this has to do because it's a different pathologic process. So in addition to that, what about the role of steroids? It definitely does not alter the disease progression. It may help if you have a patient that has an exacerbation and has overlap with COPD and asthma. But normally, chronic systemic corticosteroid does not alter the progression of the disease. Bronchodilators in the right setting may help. This is looking at the dyspnea score on patients that were started on budesonide and formoterol combination at the group that was on that had bronchiectasis and had some symptoms like asthma or a history of or COPD-like symptoms. They ended up having better dyspnea scores. This is important if you have a patient with a obstruction on PFDs, and specifically if they have a positive bronchodilator response on breathing tests. I just want to point out that the new GOLD guidelines for COPD recommend the use of inhaled corticosteroids only if you have a patient with elevated eosinophils. It's highly recommended if they have more than 300 peripheral eosinophils, because patients that do not have high eosinophils, in putting them on inhaled corticosteroid with COPD may lead to more pneumonia. So keep that in mind when you're thinking of using bronchodilators on patients that have COPD and bronchiectasis. So in addition to the bronchodilators, there's been several studies looking at the use of chronic antibiotics, specifically macrolides. This one looked at about 179 patients. About 127 actually completed the study. It was doing azithromycin 500 milligrams 3 times a week for 6 weeks. For 6 months. And the group that was on the azithromycin had less bronchiectasis exacerbation. This is very similar results of what we've seen on patients with COPD. A different study also looking at the benefits of azithromycin as a main therapy for patients with non-CF bronchiectasis. This was looking at a little bit longer, about a year. They compared to the group of bronchiectasis azithromycin versus placebo. The group on the azithromycin had also less exacerbation than the placebo group. So that's always an option, using azithromycin for patients who are constantly sick and having frequency bronchiectasis exacerbation. And lastly, there was the BLESS trial that was published in JAMA in 2013, also looking at erythromycin, and this time was 250 milligrams twice a day for 48 weeks. It was a shorter study, and the first they were looking at the exacerbations per year, reduction of sputum volume, and attenuation of decline, and that also showed benefits in the quality of life and the decline of the FEV1. So the macrolides are all possibilities that you can use on patients with bronchiectasis. Now, inhaled antibiotics is used regularly in patients with CF. The data is not very clear on non-CF bronchiectasis. There's a lot of studies looking at this. I'm just going to point out a few data or evidence that is out there. One looked at the benefits of inhaled astronam on 274 patients. It did not show any changes as far as quality of life after 4 weeks. And these are patients that are colonized with Pseudomonas. They also looked at the benefits of inhaled ciprofloxacin being done twice a day for 28 days. And in this study, it resulted in a reduction of the bacterial load, but did not affect the quality of life. In some of these studies, the recommended duration of the inhaled antibiotic was about 3 months. Colistin, which we do a lot for CF, inhaled colistin was studied in this patient population, and it did not show any difference when compared to placebo. In some of the studies, colistin may improve the quality of life, but really does not change outcome as far as long-term survival or decline of FEV1. This is a difference, looking at the benefits of the inhaled antibiotics. but more at the level of the inflammatory biomarkers and inflammation, comparing inhaled gentamicin to just saline. This was a very small study, up to 57 patients, but the group of the inhaled gentamicin had a decrease in biomarkers compared to the group on saline. And the big thing here, although the data as far as what to do with inhaled antibiotics is conflicting, and most of them does not show any significant improvement, long-term improvement, the key is eradicating the agent that is in, or the main infectious agent in those airways. Specifically, if you have somebody who's colonized with Pseudomonas. It's been looked at what happened with a patient population that were colonized with Pseudomonas, pre-eradication, post-eradication. After the Pseudomonas was completely eradicated, the frequencies of exacerbation significantly declined over a course of a couple of years. The recommended course based on this study from the Respiratory Journal was IV therapy, does not specify which one, as long as it's anti-Pseudomonas coverage for 2 to 3 weeks, followed by, or oral therapy for 3 months, followed by inhaled antibiotics for 3 months. I've done this a fair amount of times, and it's very hard to eradicate Pseudomonas. The times that I've been successful has significantly improved quality of life in this patient population. So I've talked about airway clearance measures, exercise, in bronchodilators, antibiotics, chronic antibiotics, not only oral but also inhaled. What about if all that fails? It's always an option for surgery. Now, surgery can be accomplished if the bronchiectasis is limited to a specific lobe. It can normally is done for patients that have frequent infections, and the most common reason is actually hemoptysis, frequent hemoptysis with bronchiectasis. Sometimes can be done if it's confined to more than one lobe, but ideally more than one lobe. It also has indication if the patient has multi-drug resistant tuberculosis or non-tuberculous mycobacteria, again, if the injury is localized to one lobe. And if the patient does not tolerate anything, or even despite being on maximal therapy, the disease is going to progress, and the patient is eventually going to need a transplant evaluation. The recommended is bilateral lung transplantation. Some studies say that the survival on the waiting list for patient bronchiectasis appears to be better than patient with CF, and that's because CF is more progressive and a little bit more aggressive. However, there's new, which I'm not going to talk about today, but new interventions for CF that I'm sure this data is going to be different. So I've been talking about exacerbations for quite a bit now. The reality is that there's not a clear definition of what bronchiectasis exacerbation is. Several studies define it similar to COPD. Most of the time they comment on frequent increase in the sputum volume, increased cough, increased shortness of breath. What to do in those situations? I always go back to sputum culture, make sure that if there's nothing new growing in those sputum culture that needs to be treated differently, always get an FEV1. FEV1 is an objective measurement to know if the patient is getting worse. Antibiotics, normally if we have something to treat, anything positive in the sputum culture, we go by what we normally do for CF, which is about 14 days of antibiotics. And airway clearance measures are very important in this patient population, so you keep it going if you have anyone with an exacerbation. Prognosis, it depends on many factors. FEV1 at the time of diagnosis, the lower the FEV1, the worse prognosis the patient is going to have. Patients with Pseudomonas in sputum have worse prognosis, the same as patients with low body mass index. Men tend to have worse prognosis than women, advanced age, and comorbidity with COPD. Interestingly, patients that are labeled as idiopathic bronchiectasis have a better prognosis than the ones that have identified cause. I'm not sure why that is. There's several scores to determine prognosis. This is a very long one that is easy to do. Is using age, BMI, FE1, admissions, exacerbations, MMRC, which is a dyspnea score scale that is just for 5 questions. The patient has Pseudomonas, if they're colonized with other organism, or if the disease involves more than 3 lobes, and you give them score points here. The higher the score, obviously, correlates with frequent hospital admissions, higher mortality, and higher exacerbations per year. This is one that I do in clinic, which is because it's quicker, is the FACE score that looks at the FEV1H chronic colonization with Pseudomonas. No Pseudomonas is 0 points, Pseudomonas is 1 point. Extension, if it's more than one lobe, if it's one lobe is 1 point, more than 2 or equal to, it's 2 points. And the dyspnea scale using the MMRC gives you points. And then if it's 0 to 1 is mild bronchiectasis, 3 to 4 is moderate, and 5 to 7 is severe. Severe bronchiectasis tends to have worse prognosis, tends to have frequency exacerbation, and also correlates with hospitalizations. Now, for COPD, there's a significant overlap of COPD and bronchiectasis. A lot of the patients who have pre-COPD can have bronchiectasis. This is a case of a patient with severe emphysema and severe obstruction on PFTs, noted by an FEV1 of 36%, has significant hyperinflation. I had to put 2 different pictures just to pick up all the lung volumes. This is not the same patient, but this patient with COPD had dilated airways, bronchiectatic airways on both lungs. So it's known that patients that have COPD and bronchiectasis are going to have more exacerbations. And the reason for that is because of the chronic inflammation and infection of those airways. So that's important to identify when you are seeing a patient with COPD, specifically those on the group D. So in those, you may want to incorporate significant airway clearance. So I'm going to take maybe 5 more minutes to go over some cases. So this is a case of a patient that has rheumatoid arthritis. He has chronic cough, shortness of breath. Rheumatoid arthritis can be the cause of several lung diseases. But for bronchiectasis, the pathogenesis is not clear. Up to 52.3 cases per 100,000 with rheumatoid arthritis can have bronchiectasis. Smoking and lower respiratory infections are the most common risk factor that may trigger the whole process of bronchiectasis. They do not have a very good bronchodilator response when you do a breathing test. And there's not a lot of evidence of the therapies that we use for rheumatoid arthritis and bronchiectasis, see if it slows down the lung disease. If some of those patients on that immune therapy can have more infections and can lead to higher mortality. This is the second case. This is a patient with severe bronchiectasis. You see some of the air fluid level. The same CT right next to an X-ray. You can all see that the heart is in the wrong place on that X-ray. This is primary ciliary dyskinesia. It's a syndrome. It's a congenital syndrome of immotile cilia that leads to impaired mucociliary clearance. 50% of the patients can have sinus inversus. Cartaginer syndrome is sinus inversus, chronic sinusitis, and bronchiectasis. That may be a board question to my fellows and the residents listening. Normally, the diagnosis is done with productive cough dating back to childhood, frequent ear, sinus, and pulmonary infections. And then, as I said, sinus abnormalities. The diagnostic test is measuring the nitric oxide potential in the nose. And is very rare, but you may see that. The next case is a patient with severe asthma on maximum inhaled therapy, multiple exacerbations, the CT is normally not part of your algorithm when you're taking care of an asthma patient. Has evidence if you have a patient that is refractory to the therapy. This is a CT of this patient, had an elevated eosinophil count of more than 500 and also had an IgE that was higher than 1,000. This is a patient with allergic bronchopulmonary aspergillosis. This is a slide taken from Up Today, which is probably one of the best tables that summarizes how to diagnose it. It's a patient that has predisposing conditions such as asthma and cystic fibrosis, and you need the obligatory criteria of an aspergillus skin test or IgE level specific for aspergillus. Elevated IgE concentration, normally more than 1,000. Keep in mind that if a patient is on steroids prior to getting this lab, the IgE may be less because of being on steroids. And then the other criteria where you need at least 2 is the precipitating serum antibodies for aspergillus, changes on X-ray or CT, and a total eosinophil count more than 500. The treatment for ABPA, I'm going to go back a second. So normally this is a very severe case of bronchiectasis, but normally a patient with ABPA has central mid-lung fields bronchiectasis. There is a specific radiologic sign called the finger and glove, which is mucus impaction inside the bronchial, inside the distal airway. So those are the most specific findings. Normally it's not as severe as this. The treatment is prednisone for 3 to 6 months. If the patient is refractory to that, you can add antifungal therapy. ABPA is not an infection of aspergillus. It's an immune response to exposure to aspergillus. So that's why prednisone is the first line. There's some evidence of immunotherapy, such as omalizumab, which blocks IgE, or mepolizumab, which is an IL-5 inhibitor that is secreted, that it stimulates the eosinophil migration to the airways. But this is not yet being completely approved for ABPA, but something that you can consider. When you're treating a patient with ABPA, you can monitor IgE. If the patient has abnormal imaging findings, you can monitor the imaging findings. And I think this is the last case. So a young patient with obstructive lung disease, some PFT, severe obstruction with an FEV1 of 36%, air trapping and hyperinflation in lung volumes with a decreased ELCO. You get a CT and the patient has mild bronchiectasis and lower lobe predominant emphysema. There's a patient with alpha-1 antitrypsin deficiency, which we can talk about for another hour. This is an imbalance between the neutrophil elastase and elastase inhibitor. Cigarette smoking and infection increases the elastase inhibitor production in the lung. That's why it's important to always get a phenotype. And these are the different phenotypes. We have kits in the clinic, and it should be available to everyone in the clinic. It's a free swab that gets you more than, I think, up to 15 different genotypes for alpha-1, and also a level. It takes almost a week to come back, but it's free for the patients, and it's very easy to do. The most common genotype is MM, which is the normal. MC, which is basically a carrier, has an increased risk of emphysema, specifically if a patient smokes, has a mild increased risk of developing liver disease as well. And then CC is a patient has a high increase of developing emphysema even if they're not smokers, up to 60%. And the patients that are null are going to have 100% likelihood of developing emphysema. These patients can also have bronchiectasis, and specifically mid-lung fields, and it's important to look at that. In addition to that, because the neutrophil is the most common cell affecting the patient's bronchiectasis, there are several trials looking at the inhibition of the neutrophil elastase, but those are still in phase 2. Just to summarize the work of bronchiectasis, once you confirm it by high-resolution chest CT and you have the clinical history, then you have to do the laboratory evaluation. You look at alpha-1 deficiency, immunoglobulin levels, sputum culture, and then you treat the underlying cause, Whether it's immune deficiency, you give the immunoglobulins, alpha-1, you give the protein. You start airway clearance measures either by nebulized therapy and chest physiotherapy, pulmonary rehab. And then you can consider macrolide therapy long-term if a patient has frequent exacerbations. And then important, again, get the sputum culture. If the patient has normal flora, you don't have to do anything. If the patient has other organisms that are not Pseudomonas, you can treat depending on the specific bacteria and sensitivities. Pseudomonas is where you have to attempt complete eradication and suppressive antibiotics, either by oral antibiotics or inhaled antibiotics. And non-tubercle mycobacteria, then you have to treat accordingly based on the non-tubercle mycobacteria guideline. So just to conclude, always consider diagnosis of bronchiectasis on patients with unexplained cough, frequent infections, dyspnea, and wheezing. You need a high-res CT to make the diagnosis. Important, always rule out CF. We've diagnosed CF as in adult age. Always think of immune deficiency and anything that affects airway clearance. The workup is depending on the clinical presentation. No clear recommendation on the follow-up PFT. Once you get that PFT, I normally like to get at least twice a year PFT just to look at the FEV1, which can give you an obstruction measurement on how the patient is doing. Important to get baseline sputum culture, even if the patient is doing well. Again, airway clearance measures is the most important thing for this patient population, and eradicating the Pseudomonas if it's present. And if you're going to use inhaled antibiotics or non-CF bronchiectasis, the data is, and the studies are mostly done for only 3 months. So I have 7 more minutes, so I want to thank all of you for the invitation, and I'm open for any questions.
All right, if anybody has a question, you can unmute your mic and ask Dr. Rivas a question, or if you want to, real quick, you could post it in the chat area and I can read it to him.
Thank you for that presentation, Dr. Rivas. Quick question with regard to reflux. In a patient who doesn't have a specific etiology for this problem, what is the percentage of patients who have significant reflux, and what's your algorithm for helping that beyond PPIs?
I don't know exactly the percentage. If I'm not mistaken, on the registry, it was up to 40%. Sometimes if I think that reflux is the biggest problem, I normally refer to GI. Sometimes I get impedance studies or in gastric empty studies before I do that. But most of the time, once I'm almost certain that it's the reflux, I refer to GI.
All right. Anyone have any other questions for Dr. Rivas-Perez this morning? All right. Well, Dr. Rivas-Perez, thank you so much. This is wonderful as always, and we appreciate you letting us know about this. And thanks everybody for joining us. And we'll be back here again, same time, same channel, 8 a.m. Thursday. And again, thank you, Dr. Rivas-Perez. We really appreciate it.
Thank you all.
All right. Thanks everybody. We'll see you next week.